Conference. Let me introduce my first speaker, Inger Thun, professor and senior consultant in oncology at the Oslo University Hospital in Norway, and she's going to discuss cardiovascular function and the effect of exercise training during adjuvant breast cancer treatment, results from the EBBA-2 trial.
Good morning, everybody, and thank you to the organizer letting me present these results. On behalf of the EBBA-2 group, I would like to present the final results, the first results from the EBBA-2 trial. No disclosure. The primary objective of the study was to determine whether a 12-month exercise program comprised of endurance and strength training during adjuvant treatment influence cardiopulmonary function. We also wanted to evaluate the efficacy and safety profile of the exercise program, and also to determine the recommended type, dose, intensity, and duration of exercise. The study assessment started with a pilot in June 2011, continued with the main study starting in September 2014, and the 12-month intervention was closed last week. So this is really close to the results, the possibility to have the results. Overall, you can see that it's a 10-year study design. People are included before, ahead of surgery, and we take all type of measurement, including cardiovascular function, before surgery. Then we meet them again at 6 months, 12 months, and that's what all is about today. Randomization take part after surgery. So there is a group-based exercise program taking part outside the hospital, outdoor, moderate, high intensity and weight-bearing activity, twice a week, led by physiotherapists in groups of 10 to 12, but altogether 240 minutes weekly they are supposed to be active. The control group do not have any restriction of the physical activity. They should follow only the standard care. When it comes to the study assessment, the screening are taking part in that way that when you arrive as a patient and have newly been diagnosed with breast cancer or DCIS, LCIS grade 3, you are having this information of the EBBA-2 trial. Then you accept if you accept to have the information, you are invited by phone calls of our physicians, me, myself, or one of my colleagues. The cardiovascular capacity is then assessed before surgery, 6 months and 12 months. But randomization takes part then after surgery. And the reason for this is also that when we include people before the random surgery, we do know that one of them may have metastatic disease, and we didn't want to have that. One of them may have comorbidity, who will turn up during the clinical examination and so on. So the study design, 18 to 75 years old, breast cancer newly diagnosed, stage 1 to 2, no known severe illness, heart failure, uncontrolled diabetes, etc. And they should be able to participate in exercise and no previous cancer. Exercise program, 12 months, standard care. Standard care means in Norway, the Norwegian Breast Cancer Group guidelines, which is regularly also changed due to development in the treatment. Here comes the baseline results. And as you can see here, they are on average 55 years old. They have a BMI about 25.6. 70% of the tumors were invasive breast carcinoma, 13% invasive lobular carcinoma. The tumor diameter, not that large, 7.7 millimeter. About 22% had a lymph node metastatic disease, ER positive 88%, and it's the same in both exercise and the standard care group. The randomization, which I haven't talked that much about, is only randomized and stratified by postmenopausal versus premenopausal status. Otherwise, no stratification in the randomization process. When it comes to treatment, about 70% went through breast-conserving treatment, axillary dissection were done in 13%, 12 to 13%. Chemotherapy, about 55% received chemotherapy. Radiation therapy, 77%, both groups. And no, even if you can seem like the figures are a little bit different in standard care and exercise group, no, none of these were statistically significant different. When it comes to endocrine therapy, about 60%. The VO2 is 31 milliliter per kilo per minute, which is quite, what I should say, it was a great variance, but quite high. Okay, these are the final results. And I must admit that it's fantastic that the withdrawal from the included and randomized is only 9%. People have been really hanging on to the study. All participants, 545 of those who were included and randomized, we have that 274 were in the control group, 271 in the intervention group. And here you can see that the same set point for the VO2 max, the cardiovascular function, but after 6 months overall, some had received chemotherapy, some only radiation, some nothing, other maybe endocrine therapy and surgery, or only surgery. You see that those who were in the intervention group, they did much better on 6 months already than the control group, which had a 9% or 8.9% decrease in the VO2 max. After 12 months, there was still a large difference. And in fact, the intervention group, they reached the same level as before any treatment at all. This is the overall data. When it comes to those who didn't receive any chemotherapy at all, it was about 45%. There you see that those who were in the intervention group, they had an increase in their level of VO2 max after 6 months. And this increase in level kept on also at 12 months. When it comes to the control group, they had a 2.7% decrease, and that kept on also at 12 months. So what about, is there any difference between those who get anthracyclines or taxanes? And then we'll see here. Because receiving chemotherapy is, of course, a tough setting. And we have heard a lot about that in these recent days. And as you can see there, overall, among those who received chemotherapy in the intervention group, there was a decrease until 9% or 8.9%. But here in the control arm, there was 14.3% decrease, which is a lot. After 12 months, the intervention group, they reached up nearly to the same level as before any treatment, but in the control arm, still a decrease. When it comes to those receiving taxanes, which were about 212 patients, there was a 17.5% decrease in their VO2 max at 6 months. But it did improve at 12 months, but not as good as those who were in the intervention group. So it was striking that all this group, either you received any treatment or only surgery, or you received chemotherapy, all of them had a really, what I should say, effect of being in the physical activity exercise group. So the summary and main conclusions. The EBBA-2 trial met its primary endpoint in the exercise group. All subgroups of patients so far benefited from physical activity during breast cancer treatment. And our study support incorporation of our supervised but safe clinical exercise programs into breast cancer treatment guidelines. Future direction, I think in particular, should focus on that breast cancer patients receiving chemotherapy should be offered tailored exercise program, but based on their pre-surgery level on physical function. And most of all, I would say thank you to the 545 breast cancer patients and the families. It's been a fantastic 1-year intervention. And having this around is giving me a lot of information and knowledge how to be a breast cancer patient, but also how hard it is to do trials like this. But it's been fantastic. And also thanks to my support from the financial support, Norwegian Breast Cancer Group, and all the others helping us. And this is the study group. Thank you. Thank you for your attention, and I'm happy to take questions.
If those could go to the microphone, I'll ask the first question because I'm instructed to do so while people are lining up the microphone. But, you know, this is one of 3 or 4 studies that I'm aware of in the last few years showing the value of exercise. This one is the first one to look at actual cardiovascular endpoints like VO-max. All of them show that patients do better one way or the other. And yet, it's very hard. I'm wondering how you implement that in a population in Norway. I have patients, and I want them to undergo what's called prehab, which is starting your exercise program actually before you start your chemotherapy and then continuing it during the chemotherapy. But how you can actually do that and have doctors ready to see all those patients and so forth. How do you do it in Norway?
Well, I must admit that I've seen all the patients. I've talked with all the patients ahead of surgery. It's been a heavy, heavy work. But I have fantastic colleagues, 2 of them are sitting here. And so, I think, so that's one thing which has been very, very important, I think, to be very clear and to see them, talk with them ahead of surgery. The other thing is that we have a very nice nurses and physiotherapists which has been trained and picked especially for this study. And I think if you should manage to do that in a regular clinical setting, I think it's very important to have talking with them ahead of the surgery, which I think is a clue, because then they are, then they understand the setting of being in the physical settings. We have had patients here who have never had any jogging shoes or active clothing on them, but they still come in, and it's fantastic to see how they develop. And of course, another thing is, I think, which has been very important, is how this has created a very nice, social setting for them. It's been, it's been a start to become into the EVA2 trial, which I also think is important.
Yes, ma'am.
Pam Harrison, Medscape. It's a very obvious question, but why is it important to maintain cardiovascular fitness during treatment?
Well, I think that it's a very, very important question. And the cardiovascular function during treatment will also, is what I should say, an evaluation of your physical function later on throughout life, because that means that you are maybe susceptible to decrease in certain settings. And cardiovascular function is really a signal, a marker of susceptibility to comorbidity, to overall survivorship, and also we can also see that some maybe, which I'm not presenting here, but because we are also taking ultrasound and so on, and we can see that some are very susceptible to reduce their cardiovascular function, which can be very, very important in their daily life. And a lot of patients are complaining of fatigue. Mm-hmm. I mean, you have, for 10 years, you have an 8 to 10 decrease in VO2 max throughout 10 years. Here we see more than that in 6 months, doubling. And people are complaining that they feel older, they feel aged, and so on. This may be one of the explanations.
Okay, and how well did the women do for the 120 minutes they were supposed to do at home? How adherent were they, and how were you able to track that? Yes, we have done a lot of following them, and I'm presenting that in the conference. It's 70% is adherence overall, and as I said, if there's only 9% withdraw themselves from being into the intervention control group, randomized, and then until 12 months, which is very low then. And how did you just to clarify, how did you verify or validate that there was 70% adherence?
Oh yes, we have registration every week done by the physiotherapist in those who are in the intervention group. And in addition to that, we have
measuring with the accelerometer and with, also with they're having heart rate monitors on them, and also they report also regularly, monthly, and there is a physician who has seen them monthly, those who are in the intervention group. Yeah, I think safety is also important, because I must admit that I've told a lot of patients, chemotherapy yesterday, today, keep low.
Yeah,
Because
sure.
somebody needs to have that. So I think it's very important that clinicians are along in the setting when they receive chemotherapy.
I was just thinking, if you translate this program into, maybe more North American settings, people could be asked to wear a Fitbit or something like that.
Yeah. Well, in fact, one of my collaborators and co-author here is Anne McTiernan, and she said this could be implemented in the US too.
Thank you.
MarisaWeiss, how did you modify the physical therapy regimen or physical activity regimen for people who had more extensive surgery? Let's say they had mastectomies, reconstruction, abdominal stuff. Like, how did you modify it?
Yes, very important, because subcutaneous mastectomy, maybe 30% in the mastectomy group, So that's what we did. We have physiotherapists trained for this, told and trained for this. And then we had a very nice connection and collaboration with the surgeon and with the oncoplastic surgeon and so on. So we followed the track, and so they had to then keep down, couldn't do all the stretching in the first months. And so we followed that, and that was regularly checking in and showed every patient. And every patient were also evaluated based on their own VO2 max, taken ahead of surgery. Before they started the intervention, they had to follow that, and also then taking the surgery and treatment into consideration.
Did anybody have any complications, like incisions opened up, or any kind of,
Yeah. The A is, it's the adverse events, it's been incredibly low. I was thinking that they were fainting on exercise, on treadmill, and so on, and I was very careful in how this should be done. One did fall outdoor. That's the only thing which happened, and she had to go into an outpatient clinic and had a shoulder which was, but that had been injured before. Otherwise, some complain, and then we have to take them down of fatigue during the heavy treatment. And then I said, step down on your activity level now a little bit. Come along, but not that active. So, but of course, the older ones, we have a large variation here in how they were fit. Some were not fit at all. I mean, they were 73, never been exercising. So we have this difference, but that was taken care of.
Was it mostly an emphasis on sort of core and lower body, and not maybe de-emphasized up here in terms of the whole thing?
No, the whole thing, really, and weight bearing and exercising, VO2 max, or based on their 80% of the heart rate, and so on and so on. It was really, and it's a detailed, tailored program for this setting, but also based on the exercise program which Anne McTiernan and Kerry Cornea in Canada and Anne McTiernan and Fred Hirsch has done.
Thank you.
Hi. I was very impressed that you said you actually called patients.
Yeah.
I don't think I know one human being in the United States of America who's gotten a phone call from their cancer doctor. They get the secretary.
You're
will
not
go,
one of my patients.
Well, I hope I'm not going to be one of your patients, but if I had breast cancer, I would be your patient.
I can comment on that, because the nurses told them, you will, if you accept to talk with the doctor, to see if you want to attend, a physician will call you. And that they got a name of the physician who should call.
Well, that buy-in from the physicians is very important in adherence. And actually, I've accompanied a number of cancer patients to treatments and to consultations, and I have never heard exercise be recommended.
Really?
And honestly, I think that's so important
It's
at
very
major
important.
medical centers.
Yeah. Well, that's a shame, and maybe more education like this presentation will help alleviate that. One of the biggest problems is convincing the family not to treat the patient as if they're sick when they're on chemotherapy. To let them do whatever they want to do, let them go back to work. I encourage them to go back to work. I encourage them to exercise. We're trying to implement a formal exercise program like this, but it's very difficult to do in terms of getting reimbursement, getting the doctors enough time to do it, the rehab people. But I think it's extremely important for the patient and the family to understand not to act like they're sick.
This is just a comment, but I've told some of my friends with breast cancer, we have a lot of data showing exercise improves survival. I know it's true in breast, it's true in colon, for sure, prostate. So, you know, in addition to making them feel better and improving their heart, you've got the survival benefit. So that's another reason to talk to them about it.
In fact, we are going to hear more about the survival benefit. I'm sitting in the continuous update in the World Cancer Research Fund, American Institute of Cancer Research, and in fact, we need studies who have not taken what you have done throughout your life ahead of your breast cancer, but because then it can be the activity level, the social setting ahead of the breast cancer who follow you and give you a better survival. So I think more studies are needed in order to be really concrete and saying survival benefit. But of course, it's a lot of other benefit, and we will hear more about that.
I think we probably better move on.
Okay. Just that there's definitely a benefit on recurrence in breast cancer. Right?
Yeah, it is a lot of studies, but there is a discussion.
Thank you very much.